It is truly my pleasure to introduce John this evening.
Thank you so much for that lovely introduction and for inviting me to be here. I'm gonna just absolutely bombard you with a lot of information on my favorite subject, which is how to help people with OCD. And if you treat OCD, that means you're also working with families because these conditions, they don't just affect the person struggling with them, but their entire system, their entire universe, everybody who cares about them is affected by it. So this is a very important subject. I try to give you as much information as I can in a relatively short period of time. So let's get started here. So let's just start with some basics here. For those of you who may be new to understanding what obsessive compulsive disorder is, what's interesting about OCD is most of what you need to know about it is in the name. Obsessions are unwanted intrusive thoughts, images, and urges that are associated with distress. They're unwanted, right? They're sort of coming in into your mind as if against your will. They're repetitive. They're what we typically call ego dystonic, meaning they don't line up with your assumptions about yourself, with your identity, with your values. So when people have these unwanted intrusive thoughts, they're repetitive, they're ego dystonic, we call them obsessions, obsessive compulsive disorder. So you have these obsessions, they're uncomfortable, and you do things to try to relieve that discomfort. And we call these behaviors compulsions. And compulsions are physical or mental behaviors engaged in for the purpose of seeking certainty about the content of the obsessions, right? If my obsessive thought is that my hands are dirty and maybe I'm going to get sick or something like that, then I'll have this response to that, and then I'll wash my hands, and then I'll feel certain that my hands are clean, and then I'm going to get that relief. And I'll talk a little bit more about how that cycle works in a moment. OCD is a biopsychosocial disorder, which means it's not just one thing. We can't say it's caused by this. It was once believed that all OCD is autism. We know that's not true. It was once believed that all OCD is caused by trauma. We know that's not true. We know that there's a combination of things going on. One is a genetic predisposition. We know that it's a familial disorder. We don't know exactly what genes are involved, but we're still working on that. We know that has something to do with behavioral conditioning. So this way in which we're responding to our thoughts and feelings with behaviors is causing learning to happen. And the learning might be maladaptive. So that's why the treatment that we use for treating OCD is a learning-based treatment. And it's impacted by social context. What I mean by that is different people might obsess about different things based on the values of their cultural context, their family, what country they're in. People tend to worry about things that matter to them. So it affects roughly 1 in 40 adults, 1 in 100 children, 2 to 3% lifetime prevalence. This is true across the world. Different people might be more or less likely to ask for help based on cultural traditions, but consistently, the research shows 2 to 3% of the population is going to have OCD in their life. About half of the adults with OCD have serious impairment, right? It's really impacting their ability to work or go to school or maintain healthy relationships. About a third of people with OCD have what we call moderate impairment. It's enough to make them pretty unhappy, but they might be white knuckling their way through things. And only about 15% of adults with OCD would report having mild impairment. They might say have a little OCD or something like that, something that could be treated with outpatient once a week therapy or maybe just kind of learning how to navigate it. It's the fourth most commonly diagnosed psychiatric condition after depression, substance use disorders, and phobias. So it's very, very common. Um, and I want to acknowledge also, I mean, 2 to 3% of the population, that might not sound like a very big number, but in psychiatric terms, that is a very big number. Interestingly, and I made put some thought into how this might apply specifically to the Sash Bear audience. Only about 5 to 9% of those with OCD meet the criteria for BPD. But that's actually, significantly higher than the general population as BPD. So we know that OCD is actually, increasing that number. And then if you look at it in reverse, for those who do have a diagnosis of BPD, 15 to 35%, so upwards of a third of those with BPD also meet the criteria for OCD. My experience, I work in a residential program at a behavioral health hospital in the States. um, my experience here at Shepherd Pratt has been that many of the folks who come to us needing help who have a diagnosis of BPD are either struggling with OCD that's never been diagnosed, or they have OCD-like symptoms that are part of the BPD that when you treat them like OCD, their lives actually improve. So we'll talk a little bit more about that as we move forward. So I mentioned that OCD is characterized by obsessions and compulsions, and obsessions can really be about anything, but we typically see them falling into some categories. The most common one, and the one you're probably most familiar with because it's easier to portray this on television, is contamination OCD. So a person might be extremely concerned about whether or not they're clean, whether they're going to get sick, whether they're going to spread an illness. They might be obsessively concerned with germs or chemicals or environmental contaminants, lead, asbestos, bodily fluids, blood, semen, feces. These are the types of things people might find themselves constructing their lives around, trying to avoid or trying to be certain that they're not contaminated by. Another category is called aggressive, or sometimes called harm OCD, where a person might worry about what if I snap and lose the plot or have some sort of psychotic break and I hurt somebody? I push them in front of a train or I stab them or something like that, even though I would never do that in a million years. Remember, these thoughts are ego dystonic, but the image popped in my head, and how do I know that it doesn't mean I'm about to do it and maybe I'm not safe? This can also apply inward. What if I were to just pick up this pair of scissors and cut myself for no reason? And now I don't know that I trust myself to say, well, that's my OCD. I'm going to feel more comfortable avoiding being in a room where there are any sharp objects. And you can imagine how complicated this might be for somebody who has a history of self-harm and suicidality, to also have these unwanted intrusive thoughts that are not true, but essentially OCD junk mail, lies of the brain, but still create such anxiety that avoidance and other compulsions feel necessary. A lot of people obsess about harm through negligence or being hyper responsible. So a common one is what we sometimes call hit and run OCD. And everybody has these experiences. These are just heightened in people with the condition. So I'm sure those in the audience have maybe had the experience of you drive over a rock or a stick or a speed bump, and some part of your brain says, how do you know for sure that wasn't a person? And if you don't have OCD, you think, well, that's a strange thing to think. And you kind of have some awareness that you would know. But a person with OCD might feel a sense of moral urgency to check and make sure that it's not a person, including by looking in their mirror or by driving back to make sure. So this idea of like, maybe I'm going to just miss a little detail, and that's little detail is going to result in me having committed a terrible crime or injustice against somebody, and so I have to check and get reassurance to make sure that that didn't happen or won't happen. And again, same towards the self. What if I am not paying perfect attention to taking my medication at night, and I accidentally take two when I was only supposed to take one, and so now I have to compulsively check over and over again and do other rituals to make sure I don't accidentally poison myself. Sexual obsessions are very common, represent, I think, about 12% of the OCD population will report sexual obsessions. These could be things like, what if I'm of different sexual orientation than the one I assumed I was? What if I wake up tomorrow and my orientation has changed? What if I'm attracted to something that's disgusting or abhorrent to me, my children, my pets? What if I were to snap and commit an act of sexual aggression against somebody? What if I've done something sexually inappropriate? And again, remember, everybody has all kinds of thoughts. What really is setting apart a person with OCD is that they're also getting that signal that there's a sense of moral urgency to address the thought as problematic and not treat it like the junk mail that it probably is, or definitely is in the case of OCD. Another common form of OCD we call sometimes just right OCD, where someone might be focused on things like symmetry, evenness, numbers, or doing things just so, or really being focused on things being perfectly complete. This can sometimes present as I need a picture frame on the wall to be lined up exactly in a certain way. And just because if I don't do it, it's going to bother me, but it's really going to bother me. And I can't stand the idea that I'm going to live with that bothersome thought forever. So I have to fix it. And another way this presents has more of a superstitious quality to it. Like if I don't fix this picture frame and make it perfectly aligned with the wall, somehow maybe it's going to give my mother cancer, or it's going to cause a flood in Indonesia or something like that. And all I have to do is fix it, and then I'll know that I'm not going to be responsible for causing some terrible catastrophe I couldn't imagine coping with. The first form of OCD that you find in any literature was sometime in the 1600s with the religiously scrupulous, where the church kind of noticed that people were taking their religion a little bit too far and lingering over the scruples, which is to say fine details of religious faith. So folks with religious scrupulosity might be very obsessive about um, sacrilege, blasphemy. What if I had an intrusive thought about God? What if I'm not praying or practicing my religious tradition in the exact right perfect way? And this can look like a lot of excessive prayer or excessive attachment to the literal interpretations of religious texts. It can also look like a lot of avoidance, avoiding going to church or synagogue because of a fear of having intrusive thoughts. And then there's a sort of moral version of this where instead of concern about sinning, the concern is really about committing moral crimes and being rejected by society. What if I get canceled somehow? What if I um, am not perfectly honest or didn't do the exact right thing? This is a very sort of guilt-driven concern. What if I offended somebody or somehow said something racist and I need to go over every single thought I've had today to make sure I didn't say something inappropriate, that sort of thing. These folks tend to be very self-punitive, kind of err on the side of I'm a bad person because I'm afraid that if I don't take ownership of my inherent, you know, moral contamination, then it means I'm a narcissist, and they can get very sort of deep in the weeds with these types of obsessions. Um, Sensory motor obsessions, sometimes called hyper-awareness obsessions. These are folks who get stuck on noticing involuntary or semi-voluntary processes. So this would be something like blinking or breathing or swallowing or bladder fullness, heartbeat, things like that. Even as I'm talking about it right now, I'm for sure some folks in the audience, if I were to continue talking about blinking, might sort of notice that the blinking is like I'm doing it on purpose and now it doesn't feel natural. And most of us can kind of let that go after a while. But someone with OCD, where it targets that, starts to worry, what if I never stop thinking about my blinking? What if it causes me to panic or crack up or lose my mind or my life is never the same? And then I just added a bullet point called miscellaneous because, like I said before, anybody could really truly obsess about anything. Obsess about health is very common. Existential obsessions, not being able to stop thinking about the meaning of life and what happens after we die, things like that. Um, and so that just covers, a smattering of the sorts of things that we commonly see in OCD. And like I said before, people respond to these unwanted thoughts with compulsions. So one form of compulsing is physical or overt. It's something you can actually observe. And so you might observe somebody washing a lot, right? They might be what I call a frequency washer, or you might observe somebody washing in a very ritualistic way, what I might call a process washer. So they're going over each finger a certain number of times and then flipping it over and doing that a certain number of times, and then do the next hand, and then they re-soap, and then they're making sure that they're going, up to the elbow. And all of this is designed to get 100% certainty, to get that click of I know that I washed my hands. And it can be driven by multiple processes. So it's not just, or else my hands will be dirty. It might also be this 7 degrees of separation core fear, or else I will be a murderer because I spread E. coli around the building or something like that. Checking compulsions, you might be familiar with some of these. Checking the stove to make sure it's off for fear of a catastrophic, fire. Checking locks excessively, checking possessions that you have no reason to think you've lost, but you might keep checking to make sure that you haven't. Repeating compulsions, doing the same thing over and over until it feels right, or doing it over and over to the right number out of fear that the wrong number will cause some sort of catastrophic outcome. Fixing, evening up, something touches my left shoulder and I compulsively feel like I have to make sure it touches my right shoulder or else some catastrophic thing will happen. Many people with OCD might have touching or tapping compulsions where they just get the signal that if they don't, touch the corner of this chair, something bad will happen. Very common and requires a lot of attention in OCD treatment is this concept of reassurance seeking. And this is where families often come in, reassurance seeking and confessing, right? So I have this obsessional doubt. I have this unwanted thought. I don't know how to treat it. I really want reassurance that I didn't do the wrong thing, or I'm not going to hurt somebody, or this isn't going to get me sick, or I'm not going to do something sexually inappropriate or something like that. Or that I'm not a bad person for having this thought. So I might confess this thought, or I might excessively go to a confessional at church, for example, to get somebody to tell me it's okay. These are normal thoughts. You're not a bad person. Nothing bad is going to happen. Superstitious rituals that might involve anything from numbers to doing things in a very specific order or a certain way out of fear that something bad will happen. And then a lot of avoidance, right? If I can just avoid being triggered, maybe I won't be so suffer so much. And so there's active avoidance. Maybe you're watching TV and something happens on the TV screen that's an image of something that triggers you. Maybe you have intrusive thoughts, sexualizing children, and then you see a child on a TV show or a commercial, and you quickly change the channel or turn the TV off or close your eyes. We call that active avoidance. Or passive avoidance, where you're just choosing not to engage in anything where you might get triggered in the first place. And this could be, somewhere between obvious and not obvious at all. You might have to ask the person what things they're more passively avoiding. So those are all physical rituals, things we could see. People do physical rituals because thinking about these obsessions doesn't seem to be enough, right? If I could just think about it and convince myself that the bad thing won't happen or didn't happen or isn't happening, then I wouldn't have to go and wash my hands. So we always find that there are mental rituals taking place. Some people present predominantly with mental rituals. They get underdiagnosed because the doctor says something um, sadly ignorant, like, oh, well, you don't wash your hands very much, so you can't possibly have OCD, when in fact they're spending, every waking moment doing compulsions in their head. Rumination is chief among them. The rumination is sort of like trying to figure out the obsession or solve a puzzle in your head instead of letting it go and saying, I don't know, this is my OCD. I don't need to, replay this event to try to figure it out. A mental review is a sort of form of rumination. Mental checking, sometimes people will sort of pull unwanted thoughts into consciousness to check to make sure that they can suppress them or to make sure that they're still disgusted by them. So I have this intrusive violent thought. I don't want to be a violent person. So I'm going to think a violent thought and test to see if I feel like I like it or dislike it or hate it enough. And I'm looking for that specific quality of like, oh, it's so terrible for me to reassure myself that I would never want to act on that thought. Memory hoarding, where someone might really actively try to collect memories and organize them and store them for the purpose of being able to check them and use them later out of fear that something bad might happen. I could do an entire talk on self-criticism and self-punishment as a compulsion, but I'll try to contain myself here. But one way to think about it, particularly with someone who is morally scrupulous, so they have an intrusive thought that maybe they did something bad, maybe they hurt somebody's feelings, and then they're going to criticize themselves, judge themselves. They might punish themselves. They might even physically harm themselves, cut themselves, burn themselves, put themselves in a situation where they'll be very cold or very physically uncomfortable to even the score. And the way you want to think about this is the worst thing they can imagine is getting away with some kind of moral crime, letting themselves off the hook. For these folks, self-compassion is basically the hardest exposure therapy you can imagine. So just in case I've done the wrong thing, I'm going to preemptively sentence myself for the crime, punish myself for the crime, and know that there's an evenness to it. And it's almost like a moral symmetry. Maybe I've done something wrong, but I've also at least treated myself really bad. Thought neutralizing and thought stopping. I have an unwanted thought about getting sick, and I repeat the word healthy, 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 healthy over in my head to try to block out the thought. Compulsive prayer. So this would be excessive prayer, not just being very devoted to your faith, but praying in a way that's not consistent with your faith. Too much, too long, too repetitive. Trying to get certainty that you're not going to offend God. Or sometimes compulsive prayer to try to pray away the thoughts or something like that. And then any number of counting and mental chanting compulsions. People might repeat thoughts in their head or might have a compulsion to count ceiling tiles or count steps or something like that. So we call this the obsessive-compulsive cycle, and we use it as one of the first psychoeducational components of explaining to somebody how OCD works. So as you see, it starts with this thing called an obsession, like I just explained. And an obsession is this unwanted intrusive thought. And the thing about obsessions is they're normal events. The brain is supposed to provide us with all kinds of thoughts, including thoughts we don't particularly like, but that's just how brains are. And some of these thoughts are really unpleasant. So it's normal to be like, oh, I don't like that thought. And as I said before, they can be ego dystonic. So it could also have this quality of like, why would I think that thought? That's very very strange, or am I changing? Did something happen? I don't like that I'm having this thought. So then we experience this thing called distress. Distress could be anxiety, that's the most common. It could be disgust, that's a very common one. It could be some other kind of distress, but basically the brain sending the signals to the body that it needs to get into a stress position, fight, flight, freeze, because something bad is about to happen. And like a rational person, when you're in distress, you want to try to do something about it. You want to resolve the issue. You want to solve the problem. So engage in a behavior to reduce your distress. Now, I want to be clear, not every behavior that reduces distress in a situation is compulsive. What really makes this behavior compulsive is that it's specifically tied to the content of the obsession. So if I have a triggering thought that maybe I was about to turn my car into oncoming traffic, even though I would never want to do that, I'm terrified of dying, but why did I have that thought? It must mean something. And then I take a breath and I say, well, that's disturbing. And I downregulate. Maybe I pull in a DBT skill and say, okay, I need to focus on, be mindful and pay attention to the road. And I kind of let the thought fade in the background over time. That's not compulsive, that's adaptive coping. That I worked through the problem. Alternatively, compulsion might be my fear of turning the car into oncoming traffic is that I pull over and I go into another lane and I stop the car and I repeat to myself, I would never do that. I would never do that. I would never do that. And I do it enough times. Maybe I have a special number that feels like enough. And I feel like, oh, okay, now I feel like I would never do that. And that relief that comes from that compulsive behavior triggers this thing called reinforcement. Brains sound complicated, but they're actually not that complicated. They only really have two settings, repeat or don't repeat. And we repeat things that are reinforced, and we don't repeat things that are not reinforced. And so positive reinforcement or reward that's easy to understand. I want you to do something, you do it, and I give you, money, and next time I ask you to do something, you'll be like, yeah, sure, right? We call that a job. And punishment is another kind of reinforcement. It's not quite as powerful as reward, but it still does the trick. I want you to do something, you don't do it, I cause you some sort of pain. This cycle works on something called negative reinforcement. Negative reinforcement is when you're already in some kind of pain, I'm causing you some kind of distress, and you try to this and you try that and nothing's working. And then you do any specific thing, you stand on one foot and count to 4, and the distress goes away. And then your brain goes, great, always do that. So it's called negative reinforcement because it's taking away the distress. So the loop gets closed because the obsessions, remember, are just thoughts. They're thoughts, they're images, they're urges, they're natural internal experiences that humans have. So they're having, kind of a regular flow of information, mostly, we have like 40, 50,000 thoughts a day or something like that, and most of them are nonsense. And these ones that, particularly upsetting to us are going to flow in, flow out like junk mail. And if we've established this reinforcement, what happens next is now the thought's tagged with this additional information. 1, this thought's very important. 2, how do we know it's important? Because I had to do something about it, right? 2, I have to do my compulsion to get rid of the thought. Why? Because last time I had the thought, I couldn't tolerate it. It did the compulsion, and it worked temporarily, but it worked. 3, I can't handle this uncertainty. Why? Last time I was asked to handle it, I didn't. I did the compulsion. So you kind of end up bullying yourself into doing the same behavior that strengthens the reinforcement that fuels the obsession. So if you explain this to somebody who really wants to overcome their OCD, and you say, well, if the reinforcement is fueling the obsession, making it stronger and stronger over time, how do we treat OCD? Well, if the goal is to shrink the obsession, we need to get rid of the reinforcement, which means we need to accurately identify and resist the compulsions. And then we want to practice that. So we'll practice that through something called exposure and response prevention, where we will intentionally put ourselves in situations where we have the urge to compulse. And then we will practice not doing that until the brain realizes, wait a second, we don't need to do this anymore. There are a lot of conditions that are very similar to OCD and are also treated very similarly to OCD. And I'm going to speed through these because they each kind of deserve their own presentation, but you're probably familiar with some of these. Generalized anxiety disorder, it's not OCD, but it does involve unwanted thoughts and sort of compulsive worry and reassurance seeking and avoidance. Social anxiety involves unwanted thoughts about negative evaluation, and similarly compulsive reassurance seeking and avoidance and mental review. Body dysmorphic disorder is similar to OCD, and then it's unwanted intrusive thoughts specifically about an aspect of a person's appearance, and they might have any number of rituals and compulsions for trying to convince themselves that their body part is not being observed or is not as ugly as they imagine it to be or deformed. Uh, Illness, anxiety disorder, we used to call health anxiety or hypochondriasis. This is similar to OCD, and then it's unwanted intrusive thoughts about one's health. What if this mole is a tumor? What if this headache means, I have a terrible illness? And then various compulsions that might include, Googling and WebMDing and either seeing the doctor a lot to get reassurance, or maybe even avoiding the doctor out of fear that you'll learn bad news. Panic disorder, having panic attacks, and when you add sort of agoraphobia to it, it can take on very ritualistic properties. If I don't do this, I might have a panic attack. If I do this, I might have a panic attack. So avoiding situations where panic attacks could occur. Any number of specific phobias, from animals to vomiting. So basically, obsessions about specific things and various compulsions for trying to get certain that you're not going to be harmed by those things or those things won't occur. Trichotillomania or excoriation, or otherwise known as hair pulling disorder or skin picking disorder, and other body focused repetitive behaviors. They're not OCD, but they're similar in many ways, and the treating the way that they are treated through various forms of cognitive behavioral therapy are sort of OCD adjacent. And then hoarding, which is listed in the DSM as being part of the obsessive compulsive disorder spectrum. Um, where it's difficulty discarding possessions. Many people with hoarding disorder do not have OCD, but they're often kind of lumped together. And many people with OCD do have difficulty with hoarding for specific obsessive concerns. We have a lot of other conditions. If you have one mental health condition, and I know I'm speaking to an audience that understands what it's like to love someone with a mental health condition, the likelihood is if you have one, that you have more than one. I do meet people sometimes that only have one, but it's actually pretty rare. If you have OCD, it's highly likely that you also are struggling with depression. Doesn't necessarily mean you have major depressive disorder or bipolar disorder, but it's a very commonly co-occurring concern because OCD can rob you of so many things that bring joy in your life. We also see in deeper states of major depressive disorder things like depressive rumination that can look very much like OCD and can be misdiagnosed as OCD. Well, this person keeps talking about and thinking about some event from their past, when really what's happening is they're very, very depressed, and their brain is just constantly presenting them with every mistake they imagine that they made, which is slightly different from OCD. Sometimes people will have OCD symptoms only within the context of a hypomanic or manic episode, and then when that's resolved, they don't have OCD symptoms. And so the primary issue there is bipolar disorder and not OCD. And sometimes people experience mixed state bipolar episodes where they're both dysthymic and hypomanic at the same time. So they are having what they call agitated depression. So they're tired and wired. They're experiencing a sense of dread. There's nothing in particular that's triggering them. And the predominant fear is that they're never going to go back to feeling like the way they used to feel before they started to feel this way. They can't sleep, but they're also very tired. They develop health anxiety concerns, and it's very easy to miss that. But the good news is it's also very treatable when treated as a form of bipolar disorder. Obsessive compulsive personality disorder is not the same thing as OCD. Has some similar characteristics in that it has unwanted thoughts and some compulsive behaviors, but importantly, these thoughts are ego-syntonic. A person struggling with OCPD really has come to believe that things should be done in a very specific way, and that if other people would just simply agree with them, then everybody would get along. And so it can be driven by a lot more anger than anxiety and fear. And you can imagine it's the most common personality disorder co-occurring with OCD. Post-traumatic stress disorder, again, it's about 50-50 split, actually. So whether or not someone has PTSD or OCD, there's a 50% chance that they have one, that they also have the other. There's some reason to think that people with OCD experience traumas differently than people without OCD, and that might explain why so many of them develop PTSD. We all have traumatic experiences in our lives, but we don't all develop PTSD. Importantly, some behaviors that people engage in when they have a trauma history are safety behaviors that can look very compulsive. Things like checking the locks, for example. But that's not necessarily OCD unless there's a ritualistic component that goes above and beyond what's reasonable. It's something I forgot to mention earlier in defining compulsive behavior. part of what also makes it a compulsion is that it's not realistically tied to the outcome, right? So if like you want your hands to be clean, you're supposed to wash them for 20, 30 seconds, and maybe you like to wash them for a minute, maybe even 2 minutes. It's not reasonable to think that washing your hands for 8 hours is going to get them more clean than washing your hands for a minute or two. So there's something about the excessiveness or unrealistic um, effort that makes it compulsive. Eating disorders have a lot of crossover with OCD, and conditions like avoidant restrictive food intake disorder are very, very similar to OCD. But anorexia nervosa is really kind of a different beast. May also have OCD if you have that concern, but um, it's in eating disorders that the focus on thinness is not the same thing as, well, they're afraid of eating and we just do exposure to food and they'll get over it. It's more complicated than that. I'm going to save discussing BPD for a second because I have a slide that gets into more detail. Uh, uh, Attention deficit disorder, again, not OCD, but you might find that for those who are struggling with their thoughts coming at them too quickly, they might pin down thoughts and keep coming back to them and keep repeating them in a way that's obsessive or compulsive, because that's sort of grounding and helps them kind of rein in the chaos. And so many people with ADD will develop kind of hyper-organization and sort of very OCD-like symptoms. Those on the autism spectrum are going to, because of the information processing systems that they are using, which is different from neurotypicals, are going to struggle with intolerance of uncertainty, rigidity, the need for rules, sameness. And they might engage in behaviors called stereotypies that are repetitive, but not the same thing as compulsions. They might also develop fixations, right, where they keep coming back to the same thing because they enjoy it, because of their special interest, which is not the same thing as being obsessed with something. Impulse control disorders, we often use terms like compulsive shopping, compulsive gambling. These things really aren't compulsions, though, because they're driven by impulse and an intolerance to these urges, as opposed to this kind of thoughtful and intentional desire to gain certainty about something. And sometimes people on the schizophrenia spectrum will develop obsessive compulsive symptoms in response to things like auditory hallucinations. And you might have to, as a clinician, kind of ask about, are these thoughts? People say, well, my thoughts are loud, for example. I'm having a loud thought that this presentation is going awry. That's not the same thing as me hearing it, though. The thought's coming from within. I'm aware that it's coming from my own mind. I'm not identifying as coming from outside of my mind or from a specific source. So just to take a closer look at OCD and BPD and how they might present as each other or employ some of each other's symptoms. So I have here the sort of 9 criteria that you might see in the DSM. I realize BPD, there's many different ways that people go about diagnosing it, but I'm just using this as a placeholder. So the first one that shows up on this list is chronic feelings of emptiness. Many people with OCD have intrusive thoughts about not being good enough, about being worthless, about being inadequate. Why can't I get this right? Why can't I get these? Why can't I control my thoughts? Why am I having these disgusting, awful thoughts like a terrible human being? That's going to trigger chronic feelings of emptiness. Um, Emotional instability in reaction to day-to-day events. So if you can imagine minding your own business and then you get triggered with an intrusive thought, that's going to throw you for a loop. You might have sudden bouts of anxiety, irritability, sadness in response to these intrusions, frustration, not being able to complete your rituals and get that just right feeling, frantic efforts to avoid real or imagined abandonment. So if you're operating under the belief that people are going to abandon you, what I see oftentimes in clinical context is a patient is very concerned that I'm going to stop caring about them and give up on them and fire them. And this anxiety about the uncertainty over whether or not that's going to happen starts turning into something that they need to test. And so they might be asking me a lot of reassurance seeking questions, or asking for more appointments, or standing at the door at the end of the session, trying to get a little bit more time for me to try to get me to somehow prove that I'm not going to abandon them. And then, of course, when this gets more severe, they become so distressed by the intolerance of the uncertainty there. In some cases, they might feel like they have to try to get me to abandon them, or to admit that I'm going to abandon them. Let's just get it over with, right? So is this compulsive? Is it driven by BPD? Is it driven by OCD? Could be both. Identity disturbance with markedly or persistently unstable self-image or sense of self. I mean, think about what people with OCD go through, this obsessional doubt about, am I a good person? Am I sure about my sexuality? Do I really believe in my faith? So one of the things that makes the two conditions together very, very challenging is if I have unwanted intrusive thoughts about being some sort of sociopath, like some sort of terrible, violent person. Typically, what a person with just OCD could do is sort of look into their heart of hearts, and deep down, there's some sort of self there that looks back and says, "Come on, this is ridiculous." This is part of what drives a lot of the frustration and anxiety in people with OCD is they kind of know that they don't need to do these things, but they're afraid, what if I'm wrong, or what if I don't have the moral authority to decide for myself? But imagine what it would be like to say, wait a minute, do I really want to, hit someone with my car? Do I really want to push someone in front of a train? Um, and look into my heart, and nothing looks back because I have an unstable sense of self. So I don't know, maybe, right? So you can imagine how that would create a sort of sudden sense of severity with someone who has both OCD and BPD. Impulsive behavior in at least two areas that are potentially self-damaging. The relationship between what's compulsive and impulsive is a little bit complicated. People will sometimes try to resist compulsions and say, you know what, I'm just going to do it. Or they have an intrusive thought, so I'm just going to take care of it real fast. People will also engage in checking and testing behaviors that can sometimes cause them harm. Like, I need to know that I'm not going to cut myself, so I'm going to hold a knife against my skin to prove to myself that I won't do it. In fact, maybe I'll make a little cut to prove I won't go all the way. Or I've known people to do things like stand at the ledge to try to prove themselves that they would never take their own life. So these dangerous behaviors can be problematic. And that's also, I mentioned before, this tendency towards self-harm as a compulsion, which I see is actually comes a little bit later. Inappropriate, intense anger, difficulty controlling anger. Anger plays an important role in OCD. It's very frustrating to not get certainty when your brain's telling you that you need it. Unstable, intense personal relationships, extremes in this regard. Many people with OCD, I didn't mention this before, have something called relationship themed obsessions. How do I know if I'm with the right one? How do I know if I'm really attracted to them? How do I know if I really love them? What if they don't really love me? What if they would be happier with somebody else? These could be OCD symptoms that are overdiagnosed as borderline or attachment oriented symptoms, but they might not be. Recurrent suicidal behavior, gestures, or threats. So we have this thing about harm OCD, unwanted intrusive thoughts about suicide, but those can be met with checking compulsions. We also have compulsive self-punishing behaviors. And we also know that suicidality is just elevated in those with OCD. Untreated, it can be devastating because you might not be able to work, you might not be able to go to school. Um, I should add at this point that it takes on average 14 to 17 years between the first onset of OCD symptoms and actually getting OCD specific care. So for most folks with OCD, they've had it since childhood, not everyone, but most, and they lived with it, not knowing what to call it for several years before getting diagnosed. And so you can imagine how traumatic that might be, how your brain develops around chronic invalidation of people keep telling me I'm worrying over nothing, but I'm telling you I'm terrified these thoughts are going to come true. And so I feel very alone in the world, and it's very hard for me to trust people. And lastly, transient stress-related paranoid ideation or dissociative symptoms. People with OCD can dissociate when they have lower insight into their OCD. They can often become quite paranoid. And, somebody put something in my food. I can't eat the food. I'm afraid there's something in it, but maybe they did. And they're also very adept at getting lost in thought. Tend to be high visualizers. So when they have an intrusive thought, they're really picturing it as a movie in their head, and they can get lost in that movie and truly kind of, leave the planet and get absorbed into it to the point that you have to say, hey, where'd you go? Come back. So a lot of crossover there, and a lot of compassion and empathy for people who struggle with both conditions. How do we treat OCD? We treat it with CBT. It's the best evidence-based first-line approach that we have. The C of CBT is cognitive, so that means identifying and making adjustments to these unhealthy patterns of thinking that lead people to believe that compulsions are necessary or involuntary, as opposed to compulsions are a choice that we make when we're scared and we don't know what to do. So cognitive distortions like all or nothing thinking, catastrophizing, magnifying, disqualifying the positive. These are things that you can notice that you're doing and say, hold on, this way of thinking is not working out for me. I need to, back up a little bit and try to be a little bit more objective here. The B of CBT behavioral, so changing the way you're responding. This is the most important part. We call ERP the gold standard of OCD treatment for a reason. It is so essential that you teach the brain a different response to the thoughts. Otherwise, you'll just keep getting stuck in that loop. So you've conditioned yourself, you've learned to be afraid of this, and we can reverse engineer that. You can unlearn to be afraid of this. You can learn that you can tolerate the uncertainty. You can learn that the feared outcome isn't going to happen or isn't as bad as you thought it was, or if it happens, you can cope with it. And that means you're not a slave to your compulsions and your unwanted thoughts. And the T of CBT, the therapy, working with somebody together to try to overcome something, get mastery over this condition. I say mastery and not cure because OCD is considered a chronic condition. And what that means is it waxes and wanes throughout life. And what you do is you get better and better at navigating it, at the symptoms. And you can be quite happy and you can be, quite below the clinical cutoff for whatever scale you're using to assess for OCD. But it can also be very helpful, even when you have no symptoms, to think of yourself as having OCD, because then when you have an unwanted thought and you can feel that pull, you can go, I see you, OCD, I'm not going there. Medication often plays an important role in treating OCD. The first line approach is going to be the highest tolerable dose of a selective serotonin reuptake inhibitor. There are nuances here and augmenting medications and other interventions, but I'm not a psychiatrist, and in the interest of time, we'll move on from that. But one thing you do want to consider if you have a loved one with OCD, and let's say they're on a fluoxetine or something like that at 20 milligrams, that is a low depression dose. That is not an anti-obsessional dose of that medication. So something to think about. And then family participation in treatment is very important, including reducing ritual accommodations, which we're going to talk about soon. Other treatments that are helpful for OCD, you might call them second line or augmenting treatments, acceptance and commitment therapy, which I love and do a lot of. So mindfulness-based psychological flexibility training. Dialectical behavioral therapy, I think everybody here is more or less familiar with that. And I also love that when working with folks who struggle to do the exposures and stave off, when they're trying to do something hard, they might dissociate or start becoming suicidal, have suicidal thoughts, or they might panic. So having DBT skills available to help work through these hard things and realize they can get through the other end, very helpful. Radically open dialectical behavioral therapy, RODBT, a form of DBT that focuses on people who are over-controlled as opposed to under-controlled. Super helpful with just right OCD, super helpful with people who have difficulty communicating in a way that brings people closer. People tend to push people away and not know why. Super helpful with obsessive-compulsive personality disorder and autism spectrum disorders as well. Inference-based CBT, a form of CBT that focuses on challenging the story that leads to the obsessional doubt and helping people sort of see the difference between their sense-based reality and common sense and the story that their OCD is trying to pull them into. And SPACE, the supportive parenting of anxious childhood emotions, which is a protocol for teaching parents how to support children with OCD who might not have the insight or the willingness to enter into treatment on their own. So what do people with OCD go through? What is their experience of having OCD? Well, they go through stress and anxiety, and they can be impaired in many different ways. They go through conflicts in their relationships within their family. There can be huge financial impact, both from the loss of the ability to work and generate their own income, but also how expensive treatment can be. They might also have various, medical and other, health consequences. They can also be quite expensive. And they live with pervasive guilt and a loss of meaning in their life. They work for a golem in their head that is telling them to do this, do this, do this over and over again. If you want to try to really understand what your loved one with OCD is going through, try to think about what anxiety feels like for you. Try to imagine, something that really genuinely scares you, whether it's, sharks or heights or something like that. And really think about what would it feel like to be in the presence of that, and really try to imagine what would it feel like to be in the presence of it, and be consistently reminded that you're in the presence of it several hours a day, or maybe even all day. Another way to kind of get into the head of somebody with OCD and try to understand what they might be feeling is to ask yourself what I call the at what point question. And what that means is we all tolerate uncertainty all the time without giving ourselves any credit for it because we have to in order to function. And we do it to the point of ridiculousness without really paying a lot of attention to it. So the example I give here is how much time and attention I might give to my children, making sure that they are clothed and fed and sheltered and protected. Um, on a typical day before school, and they have their lunch and they got their backpack and they're ready to go. And I've done everything possible to keep them 100% safe. And then I walk them to the bottom of the driveway and I put them on a bus driven by a stranger who I don't know anything about to what I assume was school. Right at that point, I think, well, this is the amount of effort I can put into keeping my child safe. I got to go to work. And now imagine not having that part of the brain come online. It never says, well, that's about enough. I got to move on. It says, no, your child's not safe. You have to get in the car and follow that school bus. You have to observe them getting to school. You have to be right there with them in the class, or else maybe something bad will happen to them. Now, this is kind of an absurd metaphor for it, but think about it with other contexts, right? And anything is possible, then how do you just decide to let things go? And your loved one with OCD might not have that mechanism firing on that says enough. They don't feel like the door is locked enough. They don't feel like their hands are cleaned enough. They don't feel like they're a good enough person. It's all the same thing. I mentioned before, it's a familial disorder. If you have OCD, you're 5 times more likely to have a first degree relative with something like OCD. I presented that list, generalized anxiety, something like that. We know there are associations with severity, but it's not as causal as you would think. So an authoritarian parenting style, definitely going to increase severity. Over interfering, overprotective parenting, parental criticism and hostility, high expressed emotion, positive or negative, those are all going to increase severity in a susceptible individual with OCD. But we can't really say, oh, your family caused your OCD. It's a reciprocal relationship, right? And as a parent, you're responding to your child with OCD in a way that the child is also responding to, and it's a back and forth. We know that family members are often negatively impacted by the symptoms as well, and they can get very highly involved in trying to contain the symptoms with accommodation so that everybody can get along, but then they end up working for the OCD as well. And so let's talk about accommodation. That means assisting in the rituals, right, or avoiding triggering situations. Um, we know that the more accommodation is happening at home, the more severe, the more disruption, the worse the prognosis. 60% of family members are involved in their loved ones' rituals. And we know if we address accommodation, it actually improves the outcomes. So does it look like, maybe you have a loved one with specific rules about what to touch, where to sit, what words to say. So obeying those rules would be a form of accommodation. Participating in the washing, cleaning, the checking, providing more soap and more towels, and more time to do their checking compulsions. Offering reassurance and taking confession is usually the one we have the most control over because both parties typically find that experience frustrating. And so setting some guidelines around that can be super helpful. Assuming responsibilities for the OCD sufferer so that they can continue to avoid doing things like taking out the trash. Um, co-ritualizing, spending, hours with the person analyzing, whether or not they're going to do the bad thing or whether or not this or that's going to make them sick. Again, it looks like you're helping, but actually you're just perpetuating the cycle and various forms of avoiding. Reassurance teaches the brain that the uncertainty is intolerable. Who needs reassurance? People who don't know, people who didn't get it the first time, right? Assurance is okay. Parents naturally assure their children it's okay, you're safe, I love you, it's going to be fine. That's not going to get you sick. That's not how that works. You would never do that. The first time reality check is fine. You have to be careful with someone with OCD who I say, oh, I feel so good. Now, what was that again? And so it can feel in the moment very compassionate to try to ease somebody's suffering by reassuring them, but try to remember you might be also perpetuating the cycle. So the compassionate thing might be helping them get out of that servitude to their OCD by saying, that's an OCD question, I'm not going to answer it. So what you can do is you can form a contract with your loved one if they're willing and say, okay, here's something, I'm going to help you with your OCD. Um, you're going to give me permission to not answer certain questions, or when you ask this question, I'm going to respond in this way. Very important that you always lead with compassion. Someone comes to you with a reassurance seeking question, don't get annoyed with them, don't criticize them. Say like, hey, I see you're suffering. I hate how much your OCD has caused me to suffer. I'm not going to help your OCD by answering this question. How can I help? Can I help you with a distraction? Can I help you with getting involved in a task? Can we meditate? Can we downregulate together? One way to think about how to help a loved one with OCD is what I call the 4 I's: identify, invite, interrupt, and integrate. So this is from my book, What a Family Member Has OCD. So we want to identify the compulsions, not the person of the problem. Then we want to invite them in collaborating on how to address the problem, which is the OCD. We want to help them interrupt that cycle with their permission. If we force it upon them, it doesn't work. They just get angry and come up with more compulsions. And then afterwards, when the person is freed or liberated from some of the burden of their OCD, integrating and modeling healthy behaviors. The thing I see the most often in families affected by OCD who start to really make some progress is they start to recognize what they lost and when was the last time they watched a TV show together or went to a baseball game or something like that. So really kind of bringing that back into the relationship is an important part of making the treatment stick. So what do I mean by identifying the compulsion, not the person that's the problem? Criticizing the person. Why are you doing that? What's wrong with you? It just worsens the symptoms. It makes them feel invalidated, misunderstood. And again, negative expressed emotion generally is exacerbating the anxiety that's driving the behavior. So we want to be clear about what it is we're not accommodating, right? I want to say, hey, this thing with the washing is making your life difficult, and it's also, a struggle for us to keep up with. I really want to work on this with you. How can we change it? How can we make it so that I'm doing less of your laundry in a way that helps you get out from under the OCD. And then we collaborate, right? We say, like, hey, how can we do this together? They should be involved in the decision-making process. I'm not talking about what it looks like in the therapy room. I'm talking about what it looks like at home. How can I help you get out from under the OCD? And then, with permission, let's interrupt this together. So maybe we have a list of accommodations and we're gradually going to knock them out one at a time. Maybe there's a written contract about what I can deny you reassurance of, when we can resume normal activities, when I will leave on time, even if you're stuck at the door checking. Can we agree that I will wait 5 minutes and I won't wait 6 minutes, and that we'll deal with the consequences later? That I will leave this item out on the counter because that's where it belongs, and I'm not going to hide it anymore because your OCD is running the household, and I love you. I don't work for your OCD. And if they are in treatment, hopefully they're in treatment, working as a family member with the therapist to reinforce that they do their exposure homework and that they're not avoiding things and that they're not covertly getting reassurance from you or others. Now you want to follow the therapist's lead here. Your job is not to become your loved one's therapist. Your job is to support that work and support your loved one through that work. And then finally, modeling healthy behaviors, really welcoming meaningful family activity and communication, now that it's not all about the OCD. And that can also look like addressing your own anxiety, your own struggles, your own trauma that you've gone through with this condition that has commandeered your child. So one way to just sort of think about this is, your OCD, the OCD, the anxiety, the mental health condition has hijacked, has kidnapped your loved one, and you're going to get them back, but you want to make sure that you are the family that you want them to come back to. Be the family to return to. So some do's and don'ts. Do express a desire to understand your family member's OCD. Educate yourself. Read books about it. I know I'm talking to an audience that cares so much about their family members, they would come to something like this. So there's plenty of material out there that doesn't make you an expert in the condition, but it does show that you care, and it does help if you understand a little bit what they're going through. So you can ask your family member to help you understand what their experience is. And that's fundamentally different from saying, I know you have OCD, I read the book about OCD, stop having OCD. You want to encourage cognitive behavioral treatment. You want to encourage psychiatric evaluation in a non-judgmental way. This problem, I see how much it's causing you to suffer, and we have treatments that work. We have treatments that are evidence-based. And please lead with evidence-based treatments. Just because you have some friend who tried this thing and they said it worked great for their OCD, you saw some Instagram coach or something like that, that's not the best way to get somebody where they need to be. Let's start with first line treatments, and then we go second line, third line, whatever we need to do to keep our loved ones happy and healthy. But let's start with evidence-based treatments, and do get support for yourself when you need it. Get your own therapy, join support groups. There's lots of support groups out there, and anybody wants to reach out to me later, I'm happy to connect them with resources specifically for families of OCD sufferers. They meet on Zoom and they trade notes and they talk about what's working and what isn't. Offer praise, express gratitude for any effort to improve. This is for OCD. I realize in some conditions, especially with BPD, excessive praise can also backfire and be, rejected. But speaking specifically to OCD, like, hey, I saw what you did was really hard, really, really courageous. I'm really impressed by you. Um, find humor with your family member about the OCD. I mean, don't make fun of them for having the symptoms, but because these thoughts are absurd, highlighting that absurdity with them, if they can get on board with that, that's part of the treatment. And there's a lot of laughter. I'm exposure therapist. People tell me what they're afraid of, and I help them confront those fears. And so they're always doing things that are scary and dysregulating. But we're laughing through a lot of it because we're kind of amazed at how absurd the human condition can be. Look at me having these thoughts and having to touch this thing and say it's going to kill my family. Like, it's being able to recognize the absurdity of it is part of the treatment and part of connecting with another human being. Practice mindfulness and patience in stressful situations, right? Don't get lost in your own catastrophic fears. I strongly recommend a mindfulness meditation practice if you don't already have one. Express empathy when you're withholding reassurance. I'm not going to answer that question. I see that you're in pain and I want to help, and here's how I'm going to help. And reinforce the exposure work. That's what's going to get them better. Don't attribute your family members' behaviors to a character flaw. Don't say things like, what's wrong with you? Don't personalize your family member's struggles and make it all about you. Your OCD is ruining my life. Why don't you see how much stress you're causing me? Don't criticize or mock your family member's symptoms, especially in front of other people. Don't speak disparagingly of your family member's OCD in public. Oh, her OCD is so annoying. Um, don't use OCD as an insult. We get enough of that in the, you know, in the media and online, things like that. I'm so OCD, you're so OCD. This is a real diagnosable, common, debilitating psychiatric condition that we know a lot about, that we have a lot of research into, and that is treatable. Um, don't go out of your way to point out steps not taken yet. This can be very hard to resist. Like, this is good. You did this exposure, you've done this thing, and now you're going to do this next thing, right? Try to resist that urge. Um, don't take on the role of therapist. Don't make their mental health your sole responsibility. Again, your job is to be the parent, be the husband, be the best friend. Don't give up that role to the OCD. And don't blame yourself or other people for the existence of the OCD. And as I mentioned before, really try not to get started if you haven't already. And if you are, try to walk it back with the accommodation of rituals and reassurance and taking on responsibilities that your family member has started to avoid. There are a few. The most common one is called the Yale-Brown Obsessive-Compulsive Scale, or the Y-box. And what that does is ask, it has a checklist of common OCD symptoms that a person can identify having, currently have, or having had in the past. And then it has a series of scaling questions. How much time does this obsession take in your average day? How much impairment does it cause? How much control do you feel like you have? Or questions like that. And then that spits out a number and gives us a sense of the severity. Another good tool is called the Dimensional Obsessive Compulsive Scale. So we have the Y box is a common one, and the DOCS, Dimensional Obsessive Compulsive Scale. And it asks similar questions, but it asks them within the context of 4 dimensions: contamination, concern with causing harm, unacceptable taboo thoughts, and just right concerns. I personally prefer using the docs only because when I'm working with someone, I like to see the numbers go down in the different categories together as they get better. So you can just feel like
Oh,
a dimensional picture of them as opposed to a flat number. You were at a 35 and now you're at a 22.
that makes sense. It's more dynamic, so you can actually see the improvements.
Yeah, but the Y
That's
box is an excellent tool and commonly used. If you go to a therapist for OCD and they administer the Y box, they are doing the right thing for sure. It's a linguistic problem, isn't it? Like, can people have
mm,
schizophrenic tendencies, right? I mean, I could certainly hear things that weren't there, and I could certainly fall for an optical illusion. I don't know that I would describe that as a schizophrenic tendency. I could have
right.
unstable mood. I don't know that I would call that a bipolar tendency. So I think we just have to be clear when we're using a term like OCD, that's a specific psychiatric diagnosis for which you can be tested, and the test can determine you meet the criteria for this diagnosis. You could be very obsessive and very compulsive and not have OCD. And in that sense, I suppose you could say you could have tendencies like, you're a bit of a worrywart, right? But that's not the same thing as having
Right.
generalized anxiety disorder. So I guess the question is, are you thinking clinically and objectively and psychiatrically um, and scientifically, or are we just talking about how the English language works, which is a little bit clunky?
No, that makes sense. Very similar to mood dysregulation, right? Like how severe, how often, how long, and how disruptive is it to your life, really?
Absolutely. Every family is different, and a lot of this also depends on the level of impairment and disruption it's
Mm.
causing for the individual and for the family system. But if I could give you a very kind of broad answer, I would say, you give it your best shot to kind of point out to the person, listen, I love you, and this condition is that I'm observing, these behaviors I'm observing, I see how much suffering it's causing you, and I really would like to help you to get some help, and if that doesn't work, you can't just keep badgering them about it because they can dig their heels in. So at some point, you have to say, okay, how is this condition affecting my life, and what can I do to change the way that's affecting my life? So I mentioned space, for example. I mean, that's protocol is designed for younger children with OCD, but the principles I think also apply to adult children in some way, where the focus is on really explaining to the child, um, I care about you. I love you. And this condition is not sustainable anymore. And so I'm going to be making some changes. And I want you to know I'm not punishing you. I'm not mad at you. This isn't to hurt you. This is so that I can function and so that our family can be healthier and that we can all, get along. And here are the changes I'm going to make. And then, you try to get them on board with that. It's not always possible. And sometimes you have to make very strategic decisions with your loved ones about how to support them. And it can be very challenging if there's multiple conditions happening at the same time, if somebody's especially dependent and can't make their own
Mhm.
independent decisions, or if they're neurodivergent, so obviously take care of yourself, get as much information as you can. But if someone's unwilling to go to treatment, don't just throw up your hands and say, well, there's nothing to do. Go get your own treatment and see if there are ways that you can adjust. Oftentimes, when people go to do this and they say, I have a loved one who won't get help, they get diagnosed with adjustment disorder because I don't know what it's like in Canada, but here, if you want insurance
Yeah.
to do anything, you have to have a specific, mental health diagnosis with it. But adjustment disorder is probably accurate because something's changed in your family and you're having trouble adjusting to it in a way that is causing you.
Absolutely.
That's a great question. I mean, in the interest of time, I didn't get to some of the sort of nitty-gritty of the um, diagnostic process, but one of the things that you look at is called insight. And so insight is the person's ability to recognize what's going on, to say, I have a condition that's called OCD. My OCD is telling me I have to do these things. I don't want to do these things, but I don't know how to control it. Most people with OCD uh, have very good insight, actually. It's why they're so frustrated. Like, I know better, but I can't stop myself. From off the top of my head, I think it's about a quarter, yeah, about 25% of people with OCD um, who think their thoughts are like totally reasonable. Most of them think this is unreasonable, and they're just really exasperated trying to get a handle on their mind. Um, and so those are the most of the people that you're going to see come to like an outpatient people have like good insight. No human being has perfect insight. We all get tricked by our brain from time to time, but most people though see have pretty good insight, or at least fair insight. So fair insight would be
Right.
something like you're telling me this is a OCD and that I'm not really going to get sick. And, I know you wouldn't lie to me and you're probably right, but it just really feels like, dangerous and I would rather avoid it. As we work our way down in insight, we get into things like poor insight, which is, I'm pretty sure these thoughts are correct and you have a different point of view and maybe I could see your point of view, but I just think you're wrong and, I have to do it this way. And if you're telling me I should do it some other way, I think you're just not understanding me. And you can imagine you're going to have a poorer prognosis and the symptoms are going to be more
Yeah.
severe. And then in some cases, insight drops completely through the floor. And that's when we start thinking about psychotic processes, delusional disorders, things like that, where not only does
Right.
the person believe that these behaviors are necessary, but when you try to explain to them, no, this is your OCD, they just fold it into the story of like, well, they pay you to say that, right? You're trying
Right.
to
Like a
hurt me.
conspiracy theory kind of thing. It just adds to it.
Yeah, and different medications can be very helpful in kind of waking up somebody's insight. What I do find is that when people do the work, if they can learn to trust their providers and say, okay, I think they're going to help me. I'm going to take this next step and take this leap of faith, and
Mhm.
I try to treat it like it's OCD, even though I'm not sure it is OCD, but they tell me it is.
Right.
As they do the work, as they get better, their insight also improves. If you're thinking about things through a DBT lens, the first order is making sure the person is alive. And so if the behaviors are life-threatening, whether they're coming from an innate, core self-loathing and suicidality, maybe associated with BPD, or people have life-threatening compulsions. They do things
Yeah.
that could truly harm them. Um, Including people will sometimes, lose the plot and find themselves in legal situation. They commit crimes even to try to get reassurance, hurt themselves to try to get seen by a doctor. Any number of things could happen where it can be treated as like, okay, first things first, we have to stop this behavior, and then we can get into treating the condition that's causing it. My experience has been for folks, and again, I'm biased because of the place where I work and the types of
Right.
people that I tend to see. For folks who are dealing with both OCD and BPD at the same time, they tend to get thrown around a lot from institution to institution, right? So you go to see an OCD therapist, and they realize, okay, well, you have borderline personality disorder, and you can't seem to regulate your emotions very well. I'm going to send you to this DBT place, and you're going to do a DBT program, and then come back to me, and I'll treat your OCD. And this is really a fantasy that people have, that you can just like treat one condition, and the other condition is just going to wait for its turn. Because what happens, you treat one condition, the other condition is going to respond to that.
Yeah.
So to answer your question, ideally, if you can access a treatment environment where you have people who understand both conditions, you can treat them both at the same time, because the treatment for each one is going to exacerbate the other. And this is also true with OCD and trauma. So if you have a PTSD and OCD, a lot of times the OCD is running cover for the trauma. I do these extra things so that I don't have to feel this pain. And you want me
Right.
to stop doing these extra things, fine, but then the trauma is going to come up, right? And so if you're not prepared to do the trauma work in that moment, treating the OCD is just going to cause you to dissociate and have flashbacks. And at the same time, if you don't treat the OCD, you're never going to be able to treat the trauma, which is maybe at the core of a lot of what's going on for that individual. So I'm a big proponent of treating the whole person and doing it in the most holistic way possible. But I'm not a fool. I know not everybody has access to those treatments, and that's a problem across the world that I hope can gets better. So I think that's in reference to the obsessive compulsive cycle that I was talking about before, right?
Yes.
So
Yep.
there's actually competing theories about this. So if you are more of a cognitive therapist, you're going to say the core work is happening between the arising of the thought and the anxiety, right? Because you're anxious because of the way that you're thinking about the thought. But thoughts are just, they're just writings on the walls of our brain, right? They don't have any intrinsic meaning. I can write the word cat, and you know that that's not a cat. It's just ink on a piece of paper. So if I write the word monster, you shouldn't have any stronger reaction to that, because you know it's just ink on a piece of paper. And yet we're conditioned to do that, take certain thoughts more seriously than others. So a cognitive therapist would say, let's change the way they're thinking about the thought, and then they'll realize there's nothing to be anxious about, or the anxiety is tolerable. And that's can be very effective for folks. Behavioral bias, which I think most people treat OCD have for a good reason, would say the thought happens, the anxiety happens. There's not a whole lot you can do about that, but the way you respond to the thought and the anxiety that it causes changes the learning. So you either repeatedly do the exposure, and over time, your brain realizes, hey, I'm putting a lot of energy into making this person distressed, and they keep treating it like a false alarm. Maybe I'll stop putting so much energy into distressing them, and it gets easier, right? And there's, habituation, we call this. You do the same thing over and over again, it gets easier. It makes sense. It's like lifting weights. The weights don't get lighter, your muscles get stronger, right?
Right.
Um, or another way of thinking it is you have this uh, fear association with the thought, but if we keep doing exposure to it and nothing terrible happens, or some challenges happen but you cope with them, now we're having all these non-fear associations with the thought. The thought is many things, not just
Right.
And if we get enough of those non-threat associations going, they'll compete with the threat association. So you might get anxious, but not have to do anything about it. I'm a big fan of horror movies. I love seeing scary movies. And why do we go see scary movies? Because they're dysregulating. But what happens when I see a scary movie and I get dysregulated? Like, I don't think I have to run out of the movie theater because I've had so many non-threat associations, right? Nothing bad has happened to me other than the emotion, which I kind of
Mhm.
asked for. Roller coasters are the same way, right? They simulate violent near-death experiences, but people love them, right? And they love them because of inhibitory learning through exposure. Some part of them knows it's okay to feel this way, you're not going to die. And so that concept, inhibitory learning, is a big part of exposure and response prevention. So two-pronged answer to your question. It's a simple question, but I give you a complicated answer. Either we approach it from the cognitive side and say we got to change the way you're thinking so that you don't get distress, or we approach it from the behavioral side. We got to change the way you're responding to the stress so that it actually gets better, or you learn how to make space for it. And of course, both work together.
Absolutely. And it's almost comforting and validating, John, that that wasn't a simple answer. I think if it was, we'd all be wondering, oh my gosh, how have I not already done this
Right. Well,
before?
I could have said just stop it. That would have saved a lot of time, but it wouldn't have been the right answer.
And thank you so much for being with us.
Thank you for having me. It was a real privilege.
Thanks so much, John.